Good afternoon, everyone. My name is Catherine Bardier, and I am going to be moderating the live Q&A. I am from the board of the New Hampshire Public Health Association. I want to thank our presenters, Director Tilley, Commissioner Levine, for sharing their visions for the public health infrastructure in both New Hampshire and Vermont. As a reminder, please put your questions for our two presenters in the chat box, and I would love to kick off the Q&A session. So for the first question, and this is for either of you, with a 10 to 16% decrease in the workforce, what can the public health associations, educators, and others do to help? Do you expect an education need for new public health workers? Continuing education is needed in what areas for the existing workers?
Obviously, the answer is we need more workforce. So I'm really happy to say that, we've gotten a number of grants to increase a variety of positions in the department: disease intervention specialists, epidemiologists, laboratory personnel, a whole, I'll use the word army because that's what it represents, of health equity connectors, if you will. And so we're having actually really good success in recruiting a lot of them. Some of them we are still waiting for permission to recruit because it's a legislative process, obviously, but many we've recruited a whole bunch. So I'm very optimistic there because that's going to enhance our workforce tremendously. I think the thing that needs the most advocacy, and it's in recognition of the short-sightedness of most legislative cycles where you get something done, you take credit for it, and then you lose track of it, is sustainability. Because if these positions truly are going to last 3 years and not be renewable, they're going to be short-term positions. We're never going to get the heavy lifting done that I just illustrated needs to get done. We all know that these problems don't get solved in 2 or 3 years, even though you can show by a variety of metrics you've made progress. So we really need all the advocacy support for making this sustainable, for making short-term memory turn into long-term memory, whether it's about the actual grants that have been provided, or whether, more importantly, it's about the pandemic we're living through, and that people want to forget, but they can't because we really need to plan for the next one. So I'll leave it at that for now.
Hi, Tricia. Just wondering if you wanted to answer that question as well, around the workforce in New Hampshire, public health, healthcare, and what your thoughts are around that right now, any opportunities.
Tricia did post.
Oh.
She's posted, she's thrilled with the new funding for new positions. We need the workers, but we're also optimistic. And she said she thoroughly agrees that the challenge is the 3-year funding cycle.
Excellent, thank you. Next question. We know that many of the negative health outcomes that you mentioned are associated with housing insecurity. How can we as members of the public health workforce address such an intractable problem as housing insecurity as an upstream intervention?
I think I got the gist of the question that was pulled away by administrative need, but I think the gist of the question had to do with housing insecurity.
That's correct.
And it again, I think the whole point is that huge slide that I showed at the end, where we basically have to partner with abundant community partners and governmental partners and have all of these problems looked at with the public health lens, because the public health lens really does become the compelling argument and motivating force. And the reality is every problem we have is related to housing in the end. Whether it's workforce challenges, like in Vermont, people can't move to Vermont and actually have a place to live sometimes because of housing challenges. So they choose not to move here. When it comes to substance use disorder, you can't spend your entire life in a residential care facility. You need to graduate from that to an appropriate set of housing. We'll call it, for this purpose, recovery housing, that is available for you and then allows you in a transitional way to transition to more independent levels of living over time. Every problem we have eventually relates to housing. New York State wrote a great editorial once, Housing as Healthcare, basically looking at diabetes and understanding that it wasn't the management of diabetes from the clinician's point of view that was the real issue. It's the circumstances the person with diabetes was living in and how that made them either powerful or more likely impotent in carrying out the lifestyle changes and all of the compliance issues that their clinician wanted them to have. So carrying that across all problems is really the key. And housing insecurity is just such a fundamental part of the whole equation. And of course, with an equity lens on, we know the populations that are even further burdened by the insecurity when we dig down into the data deeper.
Catherine, I know you're monitoring for different subjects in the chat. At the very bottom, Director Tilley has added 3 comments on this question.
Thank you. So, Director Tilley, in response to the question on housing, she says, we are sitting at the table with our housing and community experts. We've learned housing is healthcare. Our state health assessment is looking closely about the issues of housing in our communities and among all different populations. We've known this with lead poisoning and other healthy housing approaches, but the work is expanding. Excellent, thank you. There have also been some questions, again, both fantastic keynote speakers. New Hampshire and Vermont share a long border with populations who cross the border regularly for work, recreation, shopping, healthcare, with many care providers serving people in both states. What opportunities are currently underway or do you see as priorities for the 2 states to work together at the state policy and program level for leveraged collective resources to address health and social inequities?
That's a challenging question. Because even what we've learned during the pandemic is it's very challenging because each state often had its own policies, whether it was a policy on travel, a policy on quarantine, a mandate for this or a mandate for that or lack thereof. There were many, many differences. And we both have governors who actually talk to each other and are in the same party and communicate, I think, fairly frequently. But having said all that, it's very hard to leverage collective resources to address these inequities. And I think that's because the states have a very different approach oftentimes to how they use their own resources. So we'd have to have a commonality there to really actually work together on a common theme. I think the presentations have illustrated we have no lack of sharing of vision and no lack of sharing of what's good for the populations, and that would improve life, whatever side of the border you live on. So I think the foundation is there for sure.
Excellent. Director Tilley also mentions that there are exciting opportunities to address issues like access to labor and delivery services in rural areas. And then she says, but to Dr. Levine's response is accurate. There are differences in policy and approaches, but with similar populations and provider communities, we are communities we can start picking away at the common challenges. Excellent. Another question for us. What are the current immunization rates in each state? Dr. Levine?
So that's a very general question. You know, the answer is always, it depends how you express the rate. If you look at whole population, eligible population, whatever you want to look at. So the population we choose to look at the most, just prior to this week when the 5-year-olds became eligible, was the 12 and older population. And so when we look at the rate of at least one dose of a vaccine for those eligible for vaccination age 12 and older, it was 90.4%. If we look at fully vaccinated for that group, it was 80 to 81%. Now that we've added the 5-year-olds, that's another 44,000 people in Vermont that would be eligible. Those will go down by about 2 or 3% until we get this age group vaccinated. On the first day for registration for vaccination in that age group, we had 25% of the 5 to 11-year-olds register. And that doesn't include people who would have gone through the pharmacy systems. So I can't give an exact one. And then just the last statistic for boosters in the eligible population for a booster shot, we're in the 40-something% range so far for those getting their booster shot, which is leading the country.
Excellent, thank you. And we have time for just one more question.
There's a comment from Director Tilley on New Hampshire's rates.
Oh, thank you. New Hampshire's rates are the lowest in New England, but still higher than the US. This is another place where there may be differences in policies that lead us to different rates between the two states. Excellent.
Yes, and anyone in New England is still at a higher rate than almost anywhere else in the country. So that's the good news. The bad news is, even when you're the best in New England, we're all going through the same Delta surge right now, which is just mind-boggling, to be honest, with such incredible vaccination rates. And still, we all have, though, this is a good illustration of disparities. Maine, New Hampshire, and Vermont, the northern counties are the ones now with the highest growth in case rates and the lowest vaccination rates. So there's a clear correlation there and a clear disparity in the data when you look even at the region and each state individually.
Excellent, thank you. So we have time just for one more question. Given the geography and history of New England, can the partnership to build an equitable future through public health strategies move from a bi-state initiative to a true region-wide initiative?
You know, that's so aspirational that I would just want to say yes and end on a high note. But I don't know, it's that simple. I mean, New England is New England. We are, you know, unique in many ways. And there's a reason I think that the Northeast is the best vaccinated part of the country right now, and has the best appearance in the Delta wave, even if we're suffering significantly. So there's enough commonality across these 6 states that I would like to say that, yes, we can, and just end on the high note. But that is such a heavy lift. So I'll just leave it at that because I don't want to bring us down.
Thank you. And thank you again to our presenters for spending their time with us this afternoon, and to the audience for your active participation. Excellent questions.